It is January the 25th, 2019, and this is episode 6 of the official podcast of the Royal New Zealand College of Urgent Care. Coming up on this episode, we look at how various types of X-ray views are performed and discuss what they're intended to show. We review conservative versus surgical repair for Achilles tendon ruptures. We review ways to reduce the sting of local anaesthetic injections. We have a very strange case of back pain with injection site cellulitis. And we don't forget the glucose in the nurse's station. Okay, so welcome to episode 6 of the official podcast of the Royal New Zealand College of Urgent Care. My name is Guy Melrose and I'm your host. I'm joined as ever by our Director of Clinical Training, Dr. Dave Sorrell. Hello, Dave.
Hi there.
And welcome back. Happy New Year and all that. It's the end of January now, so the year's flying by. We'll start this week with a talk I had with a radiographer by the name of Katie, who works at the River Radiology clinic in Hamilton, and I talked to Katie about a number of things, but for this talk we've just focused on how certain views are done, specific views for specific information, and I think it's important that we understand what our patients have to go through to get these views. And I thought after we've listened to that, Dave, we'll just have a chat about the information that we need to glean from these views as they come through. So we'll listen to Katie now tell us about these views, and then we'll have a chat in a second. Okay, so we've sent a patient round for specific views, and maybe it's the orthopaedic team that has asked for those views, or maybe we've made the decision ourselves, and we've addressed all the issues that might prevent you from doing the right, the best X-rays. So the patient is compliant and has enough pain relief on board. What would be useful to know is, though, what exactly is involved in those views. So what are we asking our patient to do when we're sending them around for these particular views? So one view we often get asked by the orthopaedic surgeons to do is a gravity stress view of the ankle. What is a gravity stress view, and how do you do it, and what positions do the patient have to adopt for that one?
Right, so a gravity stress view of the ankle is used to determine if an ankle fracture may be unstable by demonstrating any abnormal widening of the medial mortise joint. So doing the gravity stress view is often done if the patient physically cannot weight bear, if they're in too much pain. It's a bit of a tricky view. Before I'd worked here, I'd never had to do it in the hospital. It's not a view that we routinely did. So this view involves getting the patient to lie down on the bed on their affected side. So if it's their right ankle that's injured, they're lying on their right side with their ankle dangling over the edge of the bed, so gravity can work its forces on it. The image is taken with the X-ray beam in a horizontal ray, so instead of shining down from the top, it's coming from the side, so coming through the anterior surface of the ankle, and the X-ray plate is put directly behind the ankle, so posterior. The legs then rotated inwards about 10 degrees to mimic the positioning of a mortise ankle view. So you're looking at the medial mortise joint.
And is it so it's only gravity that's acting on this? There's no weight or anything applied to the patient, but if we're thinking that there's instability there, there's obviously going to be some significant injury there. So is it quite a painful view for the patient in your experience? Do they seem to not enjoy lying in that position?
The few patients that I have done it on haven't complained too much. I guess it's less painful than having to stand with their full weight on their sore ankle.
Cool. So that then brings us neatly to a weight-bearing X-ray, which we do commonly for, again, looking at that ankle mortise and also in the foot for Lisfranc type injuries. So what is involved in a weight-bearing view? I mean, it sounds simple, they're bearing weight, but to get the right views, they've got to do certain things. So what do they do?
So yeah, basically, like you said, weight-bearing views involve the patient putting as much weight as possible onto the affected area. So usually it's feet or ankles. We often do knee views weight-bearing as well. For ankle views, in our department, it does involve the patient having to stand up on some stairs. The X-ray tube is physically not able to go down low enough for them to stand on the ground, so they have to do the pictures raised up so the X-ray beam can actually access the ankle. It's positioned the same way as supine images are. So for your AP, same position, mortise, internally rotated 10 degrees, but it just involves that extra weight-bearing component. Often, if a patient is in some amount of pain, I tell them that I'm only going to get them to put weight on their ankle or their foot when I take the picture, and that it will only take about a couple of seconds to do the picture. It puts them at ease a bit knowing that they don't have to stand there with their full weight on their sore limb while I fluff around setting up my positioning.
And that goes back again to good analgesia and preparing the patient for the view. So if we say to them when we're examining them, can you bear weight on this? And they obviously can't. There's probably no point in sending somebody round for a weight-bearing X-ray. But if they can give a couple of seconds of full weight, we're going to get the pictures we need and potentially move that case forward in terms of diagnosis. Yeah. So what about clenched fist views? These are views that we're often doing when we've got concerns around particularly scapholunate ligament injuries of the wrist or any kind of carpal bone abnormalities. What's involved in the patient doing a clenched fist? So
for our clenched fist series, which we also call a dynamic wrist series, it involves your standard wrist series, which is your PA, oblique and lateral, with the additional views of a PA with the clenched fist. The fist is clenched as tight as you can. We also do an ulnar deviation and radial deviation view, and then an extra lateral view with the fist clenched. So they're called dynamic views because we're taking views with the wrist moving in different positions, and it's to demonstrate any abnormal widening around the scapholunate joint.
Another X-ray that we might request would be AC joint X-rays, and in particular if we're concerned about widening of the AC joint, we ask for, I guess, weight bearing is a term for that. How do you do those when you're doing those views?
So the initial view we do for any AC joint is to do a full view of the clavicle. This ensures that there's no fracture of the clavicle, because if there's a fracture at the distal end of the clavicle, you're not going to want to make the patient hold a 3 kilo weight and cause any displacement to the fracture. So once we've cleared the clavicle, we position the X-ray beam right over the AC joint. We then get the patient to hold 3 kilo weight, letting their shoulder relax down as much as possible, and then we take the picture. So putting the weight on allows any movement if there is damage to any of the ligaments in the AC joint.
In your experience, does it cause a lot of pain when a patient's doing this? Do they complain?
I haven't had many complain. I often tell them, if you're experiencing any pain, tell me and we'll stop straight away, because I don't want to cause any more damage to the patient.
AC joints are obviously often we're doing shoulder views as well, or there may be a shoulder injury concurrently. In terms of a shoulder X-ray or X-ray series, what are your standard views and positions when somebody has a shoulder injury, and what sort of positions do they have to get in to get the adequate views when you're doing them?
So all X-ray series are department dependent. Every department's going to have a different standard set of X-rays for each body part. In our department, we have a 4-view shoulder X-ray series, whether it's a trauma, injury or non-trauma. We start with a basic AP shoulder view, which includes the whole shoulder girdle, so you're making sure you get the whole clavicle, the whole scapula, and the proximal humerus. It's common to position the humerus so the hand's facing AP, so you're in AP position. The next view we do is a Grayshi's view, which is to demonstrate the glenohumeral joint. Again, this is standing erect, just slightly rotated with the X-ray beam directly through the glenohumeral joint. So there's two sorts of laterals you can do. There's just a plain lateral, which involves the patient standing with their hand on their tummy, so their elbows pointing out, I guess sort of like a chicken wing. Sometimes you describe it to them like that. They then you can perform this many different ways. You can perform it in an AP or PA position. I personally perform mine PA with the X-ray beam shooting directly through the blade of the scapula. The plain lateral has no angle. You can also do what's called an outlet view, in which you do a 15-ish degree caudal angle. So the fourth view we do is a standard shoulder view, is an axial shoulder. This is the most uncomfortable picture to perform, whether the patient's sore or not. Often if the patient is in severe pain, we can't do this view because it involves abduction of the arm. Ultimately, you want the patient with the arm abducted out as much as you can. The way I position it, again, in radiography, there are many ways to do many views, so not every department and not every radiographer is going to do it the same. I position it with the patient seated next to the table, their arm abducted out over the table, and then their body leant across as far as they can. So we're shooting the X-ray beam down through the top of the shoulder joint.
So that's the one we need to be most aware of in terms of pain. The rest are done standing and fairly easy to position. If somebody has a dislocated shoulder, which is quite an uncomfortable thing to experience, do you do a limited series then by pain?
Yeah. Dislocated shoulders, you're not going to want to move the patient. Personally, I don't want to move the patient's shoulder. I don't want them to pop it back in or cause any more damage. So I generally perform an AP and a lateral because they're the easiest for the patient to position in.
With cervical spine views, there's the standard ones that you do. There's the AP, the lateral, the open mouth peg view, and then you also you need to visualize the C7T1 interface so that there's none of those rare but potential dislocations that you can miss. And there's a couple of ways that you can visualize that in patients that we might refer to you.
Yep.
And the swimmers is one of those.
Yep.
What is a swimmer's view, and how does the patient have to position themselves for that?
So the swimmer's view is a alternative view which is done if you can't visualize C7T1. Our first point of call, if you can't see C7T1 on a lateral, is to try the lateral again with the patient weight bearing, because it depresses the shoulders and sometimes you're able to better visualize the lower C-spine. If that doesn't work, then you'd go on to your swimmer's lateral. Swimmer's lateral, the reason you can't visualize C7T1, your lower cervical spine area, is often because the patient has quite broad shoulders, or their shoulders are really tight and raised and they can't relax them. So for the swimmer's lateral view, you position the patient with the arm, which is closest to the X-ray detector, raised, with their forearm resting on top of their head. Their other arm is by their side with their shoulder relaxed as much as possible and pulled slightly posterior if they can. The X-ray beam is then centered at your C7T1, the base of your neck, and a slightly higher dose is used in order to try and penetrate the thicker area.
So we might sometimes need to come in and help maybe pull if somebody's restricted in terms of on a spinal board or a collar, then you'll often require somebody to pull on the shoulders. But if they're mobile, then you would get them standing and weight bearing and positioning accordingly. So again, it might be one we are called upon to help. The peg view, I always see the results of that. I've never seen one done. It looks like they're standing there with their mouth wide open. Is that how you do it?
That's exactly how we do it. So because if we were to take the picture with the mouth closed, you'd get all of the teeth overlying the top of your C1, C2 joint, which is what you're trying to see, so it's not very helpful. By opening the mouth, you're able to completely visualize that joint through the opening in the mouth as the teeth are completely out of the way.
Is that a tricky x-ray for patients? Do they find it difficult for getting the position that you want them in and holding it, or do you generally find they cope with that one?
Generally, they're all right holding the position. I have had a couple of patients who have found it too funny and have laughed while they're doing the x-ray and have had to take it again. It is a bit of a strange position to hold. The main problem for us as radiographers is that everyone's anatomy is unique. You may think you've got it perfectly lined up, and then actually the base of your skull's covering half of the joint and you have to try again. But that is the nature of radiography. Every patient's different. You're not going to get a perfect picture first time, every time.
And moving from the neck down to the knee, what does a skyline view involve of the patella? Because the standard knee x-rays, AP, laterals, you can obviously see the patella, but then we often do one when we're wanting to see that patellofemoral joint a bit better. What does that require a patient to do?
So the skyline view involves, again, it's another position which can be done many ways. Most common way it is performed is with the patient lying supine or sitting on the bed with their knee slightly bent, so maybe up to about 30-40 degrees. If the patient can't bend their knee at all, if they're stuck in extension, can't do the picture because the knee or the patella is sitting flat on top of the femur. There's no way for us to visualize that joint space, so it has to be done with a bent knee. The x-ray beam comes from the distal end of the patella, and the patient has to physically hold the x-ray plate on top of their thigh in order to capture the x-ray beam.
So the compliance from the patient is needed for that x-ray?
Yes, and our detector is quite heavy. Sometimes you can use sponges or other props to help hold the board up. I haven't had a patient who can't hold it yet, but it's just another thing to be aware of. If they've got 2 broken arms, it's going to be difficult to also do a skyline view, but we work around that.
And then with pelvic x-rays and maybe lumbar type x-rays, we're obviously firing x-rays through potentially more delicate organs and the like. So we've got to be mindful of radiation exposure when we're doing these sorts of x-rays. And when you're doing x-rays of other parts of the body, do you routinely use shields for patients in regards to kind of gonadal protection and pelvic protection? Is that a standard thing that's done?
Department dependent. Again, every radiographer has a different way of practicing. Often for children, we'd be more likely to use gonad protection or lead shielding when we're doing x-rays, because children are young, they're more susceptible to any stochastic effects of radiation, so it is something we are aware of. Generally the amount of scatter radiation that occurs during an x-ray procedure is quite low. The risk of any effects occurring from that are very minimal. So lead aprons aren't generally worn for every x-ray procedure. If we're x-raying a finger, we generally don't get a patient to wear a full lead gown. The doses are a lot lower now than what they were back in the day when it was routine for everyone to wear lead all the time. If a patient requests to wear lead at any time, we definitely let them. It's their right if they want to have that extra protection. It may not be necessary, they're welcome to wear it. As for gonad protection during pelvic or lumbar spine examinations, it is case dependent. For gonad protection, because it's lead, it's going to cover anything that is under the gonad shield. So if the gonad shield is placed slightly wrong, it may obscure anatomy that's important on the picture, and then the picture's going to need to be taken again. So it's weighing up whether you're exactly positive you've got it in the right place and you're going to get all the anatomy displayed with the gonad protection in the correct place, or are you going to take the picture, the protection's slightly in the wrong place, you're covering anatomy, and then you're going to have to expose the patient to more radiation again to get an adequate image. So it's radiographer dependent.
And as you say, the patient can request it. So if they're requesting it, there's nothing that we can do if it does maybe obscure things. And just on that same note, hip x-rays, particularly in elderly people who have fallen, are quite difficult if you don't have the hospital-type beds where you've got the cassette slides for the x-ray film. So in a urgent care type setting, such as the one you work in, you really have to have a patient who can get up onto the bed and be relatively mobile, which might mean they haven't injured their hip as badly as they need an x-ray if they're in that sort of situation. So it's that kind of slight vicious circle there of if they're that bad they can't get on the x-ray, they probably have broken their hip.
Yeah, exactly.
So what movements do you have to do to get a hip x-ray of somebody? What sort of degree of mobility do they have to have?
So for a standard hip x-ray, we always do a full pelvis to begin with, so they're lying supine on their back with their legs internally rotated, which is generally the easiest of the two pictures. The second picture is a lateral. To get a lateral, patients rolled slightly on their side, so sort of half on their side with their legs slightly bent.
So with all of these films, I think it's important to make the point that patients have to be compliant and they have to be comfortable, and you'll work with them to get the pictures. It might be a bit uncomfortable, but you'll work around it. And you've mentioned a few times that there are many different ways in some cases of doing an x-ray, so you'll find a way. So liaising with you to say, this is what we'd like to see, you'll find a way maybe of doing it that's a little bit different. You'll pull one out of the rarely used book of techniques, but you're to find the picture that you need. And therefore that helps to liaise between the two sides of the clinic to get the pictures that we want. Yeah,
you're absolutely right. If there is ever a part that you want to see better, we haven't quite demonstrated it well enough, just ask. We can always try again. We can check, as you said, our book of many positions, see if there's a position that may better demonstrate, or if there's an alternative view we can try. Like I said, there's often many different views to obtain the same image.
But ultimately, the things you mentioned before about pain and cooperation may just stymie all of these things, and we may just have to deal with what we get. Yeah.
If the patient's just simply unable to get into the correct position, sometimes we do have to send ugly pictures through. It's not something we like doing. We're not proud of our imperfect x-rays, but we try our best, and that's all we can do.
Okay, Dave, so the first view there was the gravity stress view, and this is a view that Katie references not being done very much in the hospital, and it's certainly a view that I tend to only get asked to do by a orthopaedic surgeon when I'm phoning them with a Weber B fracture that I'm a little bit concerned about, and usually there is either a hint of talar shift or they've got significant medial pain concurrently with their fracture. And So it was interesting to know that it involves the patient lying on the affected side with the foot dangling off the end of the bed, and just using gravity to apply that stress to it to see if that widens up. But it's presumably not as good as an examination under anaesthetic, or obviously a CT scan or MRI scan. So what are your thoughts on gravity stress views?
Yes, it's an interesting situation, and I think I always think of them as patient stress views, because they can be a very uncomfortable thing to do, and if it's very uncomfortable, it's unlikely to be able to be done properly. So I don't like doing them, and so I think that if it's difficult to perform, then the patient needs to go to hospital for a review of that anyway. So a technically challenging, patiently challenging view, and we're being asked by the hospital to do them when they don't do them themselves. So I think it's not my favourite view in the world.
Yeah, it's tricky, isn't it? When you get asked by an orthopaedic surgeon to do something, you feel obliged. Do you push back at all against them if they ask it, or do you tend to say, okay, we'll do it, but then come back and say, well, now we've got it, it doesn't show any difference, but is that relevant when clinically I've got concerns? Do you tend to push back against these views?
I push back routinely when I'm asked to do that, because I think that you can't really interpret it unless you are manually stressing it, which is even more painful. So I tend to say this is a waiver B, it's potentially unstable, there's medial swelling, and I suggest you review the patient.
And we also then went on to talk about weight-bearing views in general. And the importance, I think, from our point of view, is we're doing a weight-bearing view to get an answer, whether it's stability of like the syndesmosis in the ankle, or whether it's the Lisfranc joint in the foot. And it has to be weight-bearing. And so if the patient isn't putting full weight through, you might be falsely reassured with the X-ray result.
Yeah, I mean, the routine one is usually the Lisfranc one, and clinically, you know that, well, you know, radiologically, the X-rays can sometimes be difficult to interpret and may miss a Lisfranc injury. And you know, if the foot is extremely swollen, they're non-weight bearing. So how can you do a weight bearing view in a non-weight bearing patient? It's a bit of an oxymoron. And so often, this will be something that I'll push back again, saying clinically, I am very concerned about a Lisfranc injury, and I suggest you review it acutely. If it's reasonably swollen, but I'm not as clinically worried, I will always try to get follow-up orthopedically, because ideally a CT or an MRI is a much better imaging modality.
Yeah, it's reassuring, isn't it, further down the track to when somebody's still got pain in that region, but they're walking on it to get a good weight-bearing view. But if in the acute phase you've got that clinical suspicion, then I certainly usually refer them on reasonably expediently to see an orthopaedic surgeon, because of that concern that if you're doing a test to tell you an answer, but you're not sure if it's being done in a way that gives you that answer, then you're living with that doubt, aren't you?
Yes, you'll get some false reassurance with these types of things, and so every time you do a test, you need to know the false positive and false negative rate for these injuries, so that you can interpret it correctly.
The numbers that you use for, say, a Lisfranc injury, do you I've been told sort of 3 millimeters is the interval, but there's also the fact that some people are different, and the comparison views are then often recommended to see if the other side the uninjured side is naturally a little bit wider than the other. So do you do comparison views?
Well, you can do comparison views. Numbers are very difficult to really quantify, and I think it's that line, clinical correlation is required, that if it looks like a duck and it quacks like a duck, it's usually a duck. And this holds true for many injuries, such as facial orbital fractures, rib fractures. So you know that the test you're actually performing hasn't got that much sensitivity. So if there's a high clinical suspicion or a high pretest probability, then you should consider getting either acutely or subacutely better imaging done, or a second opinion.
And the next one was the clenched fist views, and that's a view generally to look for the scapholunate interval and the Terry Thomas sign, the comedian with the big gap in his front teeth. When are you doing these sorts of views generally? Because I tend to find they're done later on down the line when people have persisting pain in that region. Not so much acutely, but when they've had the first day fall, unless there's an obvious abnormality on the first X-ray, which usually means there's a fairly catastrophic injury, because they can be quite a subtle injury.
Yeah, so if you're a follower of British comedy, it's the Terry Thomas sign, and if you're an American, it's the David Letterman sign. And again, a test that is not that great, and MRI is obviously the best test for scapholunate ligament disruption. It's a test that you can do, and I sometimes do, but do not rely on at all. And if I think there's a clinical suspicion, I'm going to try and get an orthopod to organise an MRI. And it's one of those ones that sometimes you do acutely when the swelling is more central carpal than just over the scaphoid. But again, it's a difficult test that has variable probability, and so MRI is a better test. But you can do it if you're concerned about that.
It comes to that kind of dilemma, isn't it, where we know there are better imaging modalities out there, but they are gated by cost and certain hoops that you've got to jump through to get there. We end up doing tests that are maybe less that in the past they were the only thing that people had, but as technologies developed, we kind of have moved on in some regards. So it is almost a slight bygone era that we're holding on to there, because we have access to X-rays, therefore we do them. But I guess what you're saying in a number of these is that if the clinical suspicion is there, then referring on for further imaging is probably in the patient's better interest.
It's another one of those scenarios where a positive test is pretty good, but a negative test isn't. And so you could argue for not doing it at all because they all need an MRI. But it's a test we still do, and I guess you have to realise why you're doing it in the first place.
And the same with AC joint views, the patient holding a 3 kilo weight to distract the potentially damaged AC joint ligaments, helps us to grade the level of the sprain. What's your feelings on these as a useful test? Does it help? Do you feel that grading is an accurate?
Interestingly enough, I do find those ones quite useful, because your grade ones don't tend to move at all, and it can differentiate, I guess, better between 1, 2, and 3. So a normal stress view is usually pretty reassuring. But again, it's another one of clinically you push on it and it's sore, and then is it mobile? So no, I feel reasonably comfortable with AC stress views. But of course, again, I guess it's another situation where it may be very uncomfortable for the patient. But I find them relatively useful, actually.
So they're a good one. And obviously you're X-raying as well to exclude a fracture. If there's a fracture around the AC joint, do you tend to refer those to orthopaedic surgeons? Are they clavicle fractures that they need to see?
The initial management's the same. However, if it's around the AC joints, then I always like to get... So distal third clavicle fractures should have an orthopaedic review at some point in time, but not necessarily acutely, in my opinion.
And management of AC joint sprains, 1, 2, and 3s, you refer through physio predominantly?
Yep.
You don't follow them up personally?
If it's a massive 3, then I do physio, who's going to do first aid physio initially, and then an orthopaedic review at clinic just in case. But repair rates are very, very low. I have seen a dislocated inferior clavicle fracture once, and of course they need acute referral.
And there's 4s and 5s as well, isn't there? Which
I can't remember whether it's a 4 or a 5, but it was the clavicle was inferiorly displaced, and the person was stuck with his arm in a forward flex position because he couldn't get it out, and that required acute GA at Starship Children's Hospital.
And then shoulders in general, obviously a dislocated shoulder is a fairly clinical diagnosis to some degrees, and the limited views, an AP and lateral usually is quite obvious with those. It's more important then after the shoulder's gone back to then carefully look for associated injuries, and the Bankart lesion is certainly one that you're looking out for. What can you tell us about a Bankart lesion in your experience?
So the two things are the bony Bankart and the Hill-Sachs. The Hill-Sachs being the divot in the humerus. The Bankarts are particularly difficult to view and interpret on the X-ray because, of course, you've got the soft tissue component as well. So if I do see a Bankart, I'm arranging orthopedic follow-up so that they can have a MRI to better assess it. And again, unless there's a really significant fracture of the humeral joint, I'm going to be sending it subacutely to an orthopedic surgeon.
Any other shoulder kind of signs when let's say you've had somebody with a dislocated shoulder, first presentation, you sling them for a wee bit and they follow up with physio. Recurring dislocated shoulders, you refer those on from a stabilization point of view. Do you do anything specifically when you're examining the unstable shoulders? Do you do any of those sort of stability tests?
Those stability tests are particularly challenging, and it could just be me. I think that I'm not very good at assessing shoulder stability, and I don't really want to dislocate the shoulder. So I tend to leave those examinations more specifically to the physio and the orthopedic surgeon. And I mean, I'm just not quite good enough in the musculoskeletal medicine. I think it's always very good point when you're doing shoulder dislocations to remember that your neurological examination prior to doing anything and afterwards, and your shoulder dislocations, if they're simple, require an X-ray afterwards as a minimum. Sometimes they don't need to require an X-ray beforehand if you can make a simple clinical diagnosis, especially if it's recurrent.
And you're referring there to the axillary nerve sensation, that badge sensation is the important one to document.
So the regimental badge region, but also for signs down at the wrist for any wrist drop, which is more debilitating, although they usually do very well.
The presence of that before you put a shoulder back wouldn't stop you putting it back, would it? In an urgent care clinic, you would still be recommended to reduce before referring.
Well, you do need to reduce it. Sometimes you're going to do it. Well, a lot of the time you will do an X-ray and there may be a fracture associated with it, and then that can pose a lot of challenges. I routinely do not reduce major fracture dislocations in the community. I would send them in to the hospital for that reduction to occur, unless it's just a chip.
And have you had much experience with the posterior shoulder dislocation or the inferior luxatio erector type ones?
Not many. I had one very interesting patient once who had a posterior shoulder dislocation, and it was associated with a seizure, and the seizure was associated with a subarachnoid hemorrhage. So that did pose multiple confusing situations, like, is it safe to sedate this person with their subarachnoid hemorrhage? But in actual fact, a lot of the time the posterior dislocations are reduced by the radiographers, and there's really not that much of a clear opinion as to what the best way to reduce a posterior dislocation is. It would seem that simple longitudinal traction may be the best. Luxatio erector, I can't remember personally seeing one. I can remember another doctor seeing one, but again, it's such a rarity, isn't it?
Then we moved on to the C-spine views, and I personally use they're called the Canadian C-spine rules when assessing whether or not to do an X-ray of the neck. I guess a lot of the major neck traumas are going to be travelling to the hospital in an ambulance from the scene of the accident or wherever. So we're generally going to see the ones who walk in by definition. I have had one person who'd come off a bike and had an axial loading neck injury, stood up and then held their head with a rolled up towel whilst they proceeded to drive an hour and a half to see us. What was interesting was they drove past the hospital in order to get to our clinic, and you saw them walking in holding their neck as they walked through the door, which was never a good sign when someone's having to hold their neck on. But the majority of people we see are going to be walking in with self-stabilizing their own neck, using their normal neck muscles. So how do you assess a neck to determine whether they need a C-spine X-ray in an urgent care setting?
So you can use one of the clinical decision rules, either Nexus or Canadian neck rule. And it's good to have that sort of thing, printed up on the wall to look at it. And in the urgent care clinic, you've got a bit of an oxymoron, because technically, if there's a high risk of cervical injury, they should be immobilized or lying down. And if you lie them down, you can't get them to X-ray. So what you do in the hospital and what you do in the urgent care clinic are diametrically opposed. But it's good to get used to examining neck injuries. And I think the most important thing is mechanism of injury and clinical appearance when they arrive. So if they've had a major axial load or something like that, then you've got to be very cautious. If they've got any neurological abnormalities, then X-ray is not actually going to rule out any significant pathology, especially skiwara, but which by definition is plain radiograph normal. So a good clinical examination, a good history are vital. And then obviously, if you've got, you should be very cautious with someone who's had a head injury and a neck injury, and it may be better to say this person needs an ambulance and a stretcher, and you don't need to put cervical collars on, obviously, anymore, because that has gone out the window. And then adequacy of view. So obviously, you have to be able to see T1 if you are really examining the C-spine.
Yeah, we talked with Katie about doing the swimmer's views and the pulling down on the shoulder views to try and look at 7T1, because that is it's one of those classic exam questions where the before and after X-ray, that it all looks normal, but then they show you the one where they do visualize that, and there's a dislocation there. So yeah, that's always one that the examiners will bring out. Just going back to what you said about the C-spine, over the years it used to be collar board blocks taping the head down, and it was a very rigid thing. But you were referring there to the kind of the change in C-spine immobilizing now. So if you had somebody in your urgent care clinic who needed to go to hospital with a neck injury, how would you deal with them?
So I would lie them flat, and I would apply manual inline immobilization by hand initially, and then you could put sandbags next to their neck, more as a reminder than anything else, or saline bags. It's actually very unlikely that more damage is going to be done, but the worst case scenario would appear to be immobilizing them in a stiff neck collar. Really, those make it difficult. They're uncomfortable. They make airway management almost impossible. So basically, just lying them flat or semi-recumbent until an ambulance can arrive. Then, of course, you move them from your bed to the ambulance bed. So it is a brave new world, but I think you can be fairly reassured that if they arrive intact to your clinic, but they really can't drive to the hospital, can they?
No. And the ambulance guys are going to be just it's their food and meat and drink to them, isn't it? They'll take over when they arrive and transfer them and tell you what to do. But yeah, I remember back when I worked in EDs, the patient who was lying there in a collar for ages, waiting for their X-ray for their neck to be cleared, and they got uncomfortable, and then they needed the loo, and then they felt nauseous, and then it wasn't a pleasant-looking thing, and so manual immobilization, as you were saying, and then the sandbags and a bit of tape is considered enough.
Don't be too fussed about the tape. I mean,
if you have to leave them, then it tapes the bags from falling away. I guess that's if you have to walk away. Any other thing? Do you ever do flexion extension views or thoracic outlet views or anything like that if you're dealing with people who've had like stinger type injuries at rugby or anything like that? Or do you leave those for specialists?
Personally, I leave those for specialist interpretation. If they want to do them, they can. If I'm asked acutely to do flexion extension views, I will push back and not do them.
So moving on to the next one was patella skyline view. I found this interesting because I'd never thought about how they were actually done before, and the idea the patient has to lie there and hold the board themselves, the X-ray cassette themselves, was interesting to know. But when do you do patella skyline views, and what are you looking for when you actually do them?
So technically, you're looking for patella injury, be it dislocation, fracture, osteochondral fracture. So it's when you're specifically looking at patella injury. And I was not aware of how technically challenging they can be. But and of course, if you've got the juvenile patient who is not skeletally mature, of course, you're not going to get all the information you want to get with regard to osteochondral injuries. So they can be much bigger than what they appear. Certainly, post-dislocation, they're very, very useful to look for those osteochondral or other fractures along the patella.
The majority of fractures, I seem to recall, you see on the lateral more than the wide. I anecdotally, at least, tend to see them on the lateral there, and the osteochondral fragments secondary to patella dislocations, I tend to see more on those skyline ones. But
well, you can get a vertical fracture of the patella, and of course that's up on the lateral.
We briefly talked about the gonad protection and the scatter radiation and the like after that, because we went on to then talk about hip X-rays, and this goes back to what you were saying about the C-spine views and hip X-rays in an urgent care setting. Certainly in an ED, the patient gets taken on the bed into X-ray, the X-ray cassette goes into the bed, patient's X-rayed, they're wheeled back again. I'm certainly not aware of any clinic having those beds, and if they're lucky enough, they're quite chunky, so then fitting through doors is a problem. So there are issues with getting patients who have injured hips in an adequate position. So if you've got somebody who clinically looks like they've done a neck of femur fracture who's hobbled into your clinic, getting an X-ray might be too much difficulty.
Yeah, there are a few clinics that have the ability to wheel the patient in a stretcher to X-ray, like Counties Care, but most of us don't have the ability. And I have been involved in a few situations in the community trying to do hip X-rays and manually lifting patients onto beds. I mean, in ED, you do the resus trauma hip views, and so you can see the dislocations in the neck of female fractures. But in the urgent care clinic, it's amazing if you get one of those views, because usually you shouldn't be able to get one of those views. So should clinics be more mobility accessible, or will that increase the severity of the injuries? I mean, ideally, it would be nice to be able to wheel a stretcher into a radiology room and get an X-ray, but that's really the emergency department's role a lot of the time, I believe.
Yeah, I think I most commonly will X-ray hips when somebody's fallen and you're maybe thinking of pubic rami fractures and the like, where they're mobile but they've got discomfort or pain. And obviously in kids we'll do the SUFI X-rays, the kid will often be able to hop up onto a bed to have their X-rays to exclude a SUFI.
Or Perthes.
Or Perthes, but yeah. And I guess at the end of our talk, we just talked about how every urgent care clinic has to have an X-ray on site. It's part of the standards, and so the radiographer is part of the urgent care team, and getting the right X-rays is a team game. We have to ask the right questions, and then they can hopefully provide the right answers. So working with them is important. And with Katie, we went on to talk about a number of things which we'll release in future podcasts. And they kind of evolve around that theme of cooperation and teamwork between the two areas to get the right information. So we'll certainly hear from Katie again over the coming months. But yeah, I think we've covered most of the X-rays that we do in urgent care, or the extra ones that we do on top of the standard ones. So hopefully people have found that useful. So the next segment will be the nurses' station, so we'll pop over there and talk about that in a second. Okay, so I'm here with Amor Kisling, nurse practitioner in urgent care. We have a very quick nurses' station today, a simple thing, but something that is very important, because if you get it wrong, it can give you false reassurance or a very inaccurate reading, and that's finger prick testing for blood sugars. It's an important thing to do because you shouldn't ever forget the glucose, is the old mantra. So in urgent care, if a patient comes in to triage who is sick or is known to be diabetic, then it is very important to get a blood sugar reading. And there are a number of things that can give falsely positive, but the most common that we would come across is the residue from sugary things such as fruit on the fingers of the patient. And we don't know, unlike in a hospital setting, we don't necessarily know what they've been doing prior to coming in. So more, what ways are best to clean fingers prior to doing the finger prick?
So usually it's recommended to just clean with alcohol swab, but recent studies have shown that washing the hands with normal tap water actually gets rid of more of the sugary residue on fingers than alcohol swab. I think you've got to wipe it about 5 times to get similar effect, the same as tap water. So it's just something to remember, especially when you have patients sitting out in the waiting area. They might have been eating something out there waiting for a couple of hours. If you want to do a blood glucose, just get them to do a quick hand wash to try and get an accurate measurement.
Yeah, and if it's a very sick person and the alcohol swabs are convenient, then using that is certainly commonly used. But it's not just a case of giving it a little wipe. You've got to really thoroughly clean the finger, so it needs a good few scrubs and then let
good rub, yeah.
Yeah. And it is important because you might get a falsely positive, a patient with a decreased conscious level might be profoundly hypoglycemic, and if they've been trying to adjust that by taking some jelly beans or something, that residue might be on their finger, and you might get a reading that's higher than it actually is. So it's important for accuracy's sake to clean it. So water's the best thing. Alcohol swabs are okay, but you've got to make sure that you do more than just a simple wipe. You've got to physically remove it, which is why washing your hand under the tap is better. And another study that we found looked at hand sanitizer solution, and that didn't seem to have any effect, did it, on false readings? So hand sanitizer.
Patients probably wouldn't be using hand sanitizer, but we might have it on our hands and touching them. So but as you said, it doesn't affect it, so which is good.
So it's a good little tip. I guess it's something we could overlook, and it's probably something that the doctors would be more likely to do incorrectly because we don't do it as often. But if you think, we need to check a glucose, and you just go and stab the finger, get the blood and get the reading, you've got to make sure it's coming through a clean a clean finger. And we'll link to the articles there for people to have a read. There's a good long one that talks about the other things that can affect a blood glucose reading, things like profound anemia. So people can have a read of that. But in terms of just the little take-home tip today for the nurses in triage, or when dealing with a sick patient in resus, or for the doctors who think, I know I'll do the blood sugar myself, make sure that finger is cleaned thoroughly of any residue prior to doing it. So a quick and easy one today, but thank you, Amor, once again for sharing your time. And,
Not a problem.
We'll catch you next time. Thank you.
All right, thank you.
So Dave, glucose in urgent care is obviously a simple test, but it's a very important test. It can give us a lot of information, and the don't ever forget the glucose is part of the kind of the ACLS mantra. I guess the important thing when doing blood sugars is to remember that you can get false positives if you're doing it through the finger prick test. I tend to try and do them with if I'm doing a venous sample, to use the venous blood to get a reading. But not forgetting the glucose is the important thing. And if you're a doctor doing it, making sure you've cleaned the finger adequately so there's no contamination is obviously the important thing.
Yes. I guess the question is, what's the best way to clean a finger? Is it soap and water under the tap? Or because what we tend to do is just use the METHS wipes to clean the finger first, and perhaps we should be a little bit more careful about what we call a clean finger.
Yeah, I think certainly if somebody's got marmalade on their finger or something like that, then you probably get a fairly high reading. But if they've handled a lolly that day, then a bit of residual sugar, if it gives you that false reading, then I guess it's good practice to clean it. I was told that you just clean the finger with wipe it with water is adequate. I guess if you do use the alcohol, then you've got to let it to evaporate and dry. But yeah, usually if somebody's quite sick, we'll be doing it off the bloods at the same time if they're one of those more acutely unwell patients. It's an important thing to always remember. It's amazing how often, if you're making a referral with somebody who's non-specifically unwell or to the medical teams, they will usually ask for the blood sugar, and so it's good practice to have it on hand.
We now have the combo keto sticks in our clinic. I haven't actually managed to use them yet, but if you've got a type 1, you can tell whether that patient has capillary ketones and therefore by definition DKA. And of course there have been rare cases of non-hyperglycemic DKA. So I'm looking forward to being able to use one of those strips at one point in my career in the near future.
Yeah, again, they give you a good instant reading. So these kind of point of care tests, as they develop and as the price comes down, because the blood sugar ones have been around for ages, but I guess going forwards, it's going to be something that urgent care will deal with in the future. The access to point of care testing is going to come down in price and increase in availability, and it will certainly change the way we work. That was the nurse's station, just looking at blood sugar taking. So we'll just move now to review the one urgent bite that we've had this month. That was looking at how to reduce the sting of local anaesthetic injections. So the acidity of lignocaine is well known to cause a bit of a sting when it's being infiltrated, and there are various ways that were mentioned in some of those articles that I linked, from warming the solution, injecting slower. Some people use bicarbonate to buffer it. What are your thoughts on reducing that sting of the injection or getting around maybe children with a wound that needs suturing? What are your thoughts on this one?
So Topicaine is a great product that we stock in our clinic and a lot of the clinics around us, and it's kept refrigerated, and 0.1 mil per kilogram is put in an open wound and then usually covered, hopefully with an occlusive dressing. And then after 30 to 60 minutes, you'll see the adrenaline blanching effect, and it's usually quite numb. I routinely use that for lacerations that I either need to explore or close in children who I feel might be sensitive to injecting them straight away. And then to check that it's completely numb afterwards, I usually have a very small volume, again, 0.1 mil per kilo of lignocaine without adrenaline, with a very fine needle to just test out the wound to see that it's, and to make it completely numb, because you don't want to be halfway through suturing a wound and the child screams with ouchiness. Laughing gas is also a very good adjunct because it works so fast. Often with a slightly older child, you can say, hey, let's get you breathing this laughing gas and then we'll inject. And then obviously as small a needle as possible with the correct length. So you're going to have to put it in once on each side. Warm the local anesthetic in your hand. So draw up the syringe, hold it in your hand away from the child so they can't see it. And of course, electronic distraction is also a great technique. The iPad or the iPhone, and certainly have been studies doing on that, that children will often feel a lot less if they're concentrating on their favorite game or movie or whatever. And you'll notice that where you can't even examine a child because they're so intent on the phone, perhaps that's something that could be done as well.
Yeah, distraction certainly works. There was that article about swearing reducing pain, and that seems to be something that maybe it's distracting people by shouting obscenities whilst you inject them, but yeah, distraction is quite a good technique. And I find that if you tell somebody the injection is going to sting and they expect it, they always say it was less than they expected. But if you tell them, oh, you're not going to feel a thing, or if you don't forewarn them, that little bit of pain seems to be, they seem to feel it more. So sometimes expectation of making sure that they're aware they're going to feel some pain. It's similar with the methocaine eye drops. They look at you with a strange look if you don't tell them it's going to sting. But then if you do tell them, they often say, oh, that wasn't so bad. So prepping the patient is important. How much does the Topicaine cost? Is it an expensive product?
I am not actually sure how much it costs. I know that it can't cost too much, otherwise we certainly wouldn't stock it. I gather it's relatively inexpensive. I can't tell you whether it's MPSO or not. We get it in the pre-filled syringes and just keep it in the fridge. But I guess that's something that I might have to look up for you.
Cool, but it works well, and it's an important thing to think of. And what you're saying when you're putting that Topicaine on is that you're actually waiting time. So you've got to explain to the patient and to the family, this is going to take time, so we'll put this on, and then I'll go and do something else, and then we'll come back, and you've got to sort of prepare it in stages, a bit like the ICE article that I referenced that seemed to show some, they called it cost-effective pain reduction by just using a bag of ice. But again, that took time to apply it and leave it. So maybe the Topicaine is more reliable than the ice. But not rushing these things is probably important. So I guess if one thing is taking your time to warm it up and tell the patient what to expect and get some distractions in place and go slowly with the injections. At the end of the day, it's going to give you a better result than just rushing in and stabbing away. So cool. So that was the one bite, because it's been a shorter month this month. We'll move now to look at some news items. So the first article I just wanted to pull was from the BMJ, and it's going back over old ground, but I thought it was worth discussing as it's relevant to urgent care. And that was the article that looked at operative versus non-operative management of Achilles ruptures. And this is something now that's been known for about 10 years, I think you were saying when you look back at it, or over 10 years. And it really comes down to a slightly improved re-rupture rate if you have it surgically repaired. But that only really comes into play if you're maybe an elite athlete or...
So it's very important to think about the indications for Achilles tendon surgery. So from my point of view, a super athletic person, a delayed presentation. So delayed presentation is a key important one. And the question is, what is a delayed presentation? So certainly 72 hours would be a definite cutoff. Some would say 48 hours, but I think at 72 hours, an Achilles tendon rupture presents to you, then you need to talk to the acute orthopedic team as to whether they're going to accept it. And an open wound involving an Achilles laceration is probably something that should be consideration. Re-rupture Achilles are usually surgically repaired. And remember that most of the time, surgeons are not going to want to operate on a smoker. So they should also be a non-smoker. So that's the rules that I go on, and it's extremely rare to refer someone. And in the situation where we are, you can't ring a public hospital and say, "I've got a super athletic person, can you operate on that?" It's quite a challenging thing to do. So you need to have a very friendly sports medicine orthopedic surgeon that you have the private number to call. So it is quite challenging, and I think this all arcs back to the groundbreaking study by Bruce Trottle and Peter Poon in 2007, which showed that surgical repair was no better than casting. And I think that we should always think of that. And what I'm reminded of when I think about Achilles surgery is the famous Australian sprinter Peter Norman. So Peter Norman is famous in 1968, he stood on the podium with the two other African-American sprinters who were protesting for equal rights. And he had Achilles surgery and nearly lost his leg. And there is a famous quote from 1985 where one of the surgeons said, "You can't cut off the leg of an Olympic silver medalist." And so he nearly lost his leg because of Achilles problems and Achilles surgery. So there are complications from surgery. So surgery should always be thought of carefully. And if non-surgery is as good, then perhaps that's the way you should go.
So I'll put the link in the show notes so people can read this, because it is, as I say, going back over old ground, but it brings together all the studies up to date. And it certainly doesn't seem to change our practice at this stage, but it helps to reaffirm it. How do you manage Achilles ruptures personally? Obviously, an Aquinas cast initially. Who do you refer them to, or do you refer them on day one? How do you personally deal with them?
So if they're having conservative management, I would put them in a gravity Aquinas cast and get them followed up at day 10 with an orthopedic surgeon, whoever you can get, and we have one orthopedic surgeon that follows them up.
And when does physio normally begin? When that active physio? That's the one area I found to be a little varied in amongst some orthopedic surgeons, from quite early to waiting a bit longer.
So the problem is really who is managing the patient. So if you're managing the patient without orthopedic input, then you can decide. If an orthopedic surgeon is managing the patient, then really it's up to the individual orthopedic surgeon. So you need to know what their protocol is. And when I sort of surveyed a group of orthopedic surgeons at North Shore Hospital, there was no general consensus. And so basically, do what your surgeon wants. But early mobilization is probably very good, as long as your surgeon's happy.
Fair enough. So we'll move on just to the next news item, which was an article in Stuff. And we talked over one of the Christmas bites about Fuchs injuries, and you talked about Lime scooter injuries. And it was just interesting that Stuff had an article that ACC here in New Zealand had paid out $200,000 so far in the 3 months since the Lime scooters had appeared in Auckland. So it's certainly goes to your point before that Lime scooter injuries, you were predicting you were going to see more of them as time went on, and not just the Lime brand, but any scooter. There's a lot of kids who got scooters for Christmas, and there's all sorts of electric skateboards and kind of these personal travel devices that people can now get to travel that last mile from the bus stop to work or whatever. So it went to your point there on these scooters and their injuries. And you were saying there's been an incident down south just today, I think.
Yeah.
I missed on the news.
A teenager on a Lime scooter has been seriously injured in a crash with a truck in Dunedin. Emergency services were called to the crash at 1:45 a.m. near the intersection of Dundas Street and Cumberland Street. So that person is currently in Dunedin Hospital, and there are no more details available, although there is a video of the truck on News Talk ZB's website at the moment. So, I mean, yes, the story just gets bigger and bigger. And then, of course, I had a very interesting case of a chap who came off and had multiple abrasions and also a very swollen hand. And so I sent him into hospital for a further evaluation of his hand, and he had a CT. So I did do an X-ray, which showed a triquetral fracture, and it looked quite big to me. And it's very rare to actually operate on triquetral fractures. So we went in and had a CT which showed both pisiform and triquetral fractures, and they did elect to manage it conservatively. But conservatively is very challenging when half the skin of the palm has been removed. So he's having dressings and then a splint, and then he will go into a cast when his skin is intact. But there certainly are some very challenging and interesting injuries from Lime scooters.
And that's an interesting point, actually, we could move on to, that road rash and fractures are tricky, because how would you, let's say this was just a foosh from a skateboard or a scooter on, and they had a suspicious scaphoid injury, but they had abrasions up their arm. You can splint suspected scaphoid fractures if there's nothing on the X-ray reasonably, so you would probably manage that with splinting and daily dressings, I guess. But then what if they had a Weber B fracture of their ankle and also abrasions right down the leg that needed dressings? It adds to the complication of managing these, doesn't it?
Oh, absolutely. The complexity is quite challenging, and those are sort of ongoing surgical decisions as to, and so regular dressings, immobilization, very complex questions that may be better to be managed via the hospital, even if they're not in the hospital, because they may need to have district nurses visiting at home with a cast or a back slab that's removed, or they may need to be elevated in hospital. So those are complex decisions that need to be made between hospital teams and outpatient teams, perhaps.
So yeah, everyone look out for scooter injuries as they take over the world. Another interesting case, this was one that just raised an eyebrow really, and it was reported in the New Zealand Herald, but it was a case from Dublin of a man who presented with to an emergency department there with back pain, and was also found to have cellulitis in his arm. And I guess what you might be thinking, what are the differentials of someone with back pain and cellulitis? And it turned out that this man had been injecting semen into his arm to alleviate his back pain, and then those injections had got infected and caused his cellulitis. But he'd actually presented apparently with the back pain was his main concern. So an interesting case. You certainly have to think of things when particularly young men come in with back pain, and particularly here in New Zealand where people will try and put things under ACC, you've got to be always thinking of infective causes and discitises and epidural abscesses and the like. So taking a temperature and being mindful that there may not have been trauma is obviously an important thing. I don't know if you then notice cellulitis in the arm that you would immediately think to injecting themselves with semen, but yeah, it was. I thought that was an interesting case to, takes all sorts to make a world.
Yes, it's certainly not the thing that first jumps into the the differential. And certainly I don't think there's any therapeutic use of injecting semen, and hopefully he's learned a lot from that. It certainly does pop up in all the news feeds, that particular story, virtually all the way around the world. But yes, sometimes I think outside the square when, so injection cellulitis, I mean, you'd be thinking about anabolic steroids as well, of course, and certainly we would see a lot, quite a few of those sorts of cases of cellulitis from anabolic steroid injection.
And is there any correlation between intravenous drug use and spinal abscesses? Does that?
Yes. So when you're thinking about spinal epidural abscess, you think of the risk factors, and one of them is intravenous drug use. So an IVDU with severe back pain, you should have alarm bells, especially if you've got an IV drug user with fever and back pain. It's like that's MRI territory for acute referrals.
Yeah, so I guess this case, had they come through severe pain and cellulitis in the arm from what looked like injections, you'd probably be thinking along those lines. And then I think they did some imaging, and then how it all came out in the end, it was slightly more bizarre. But yeah, you don't want to be missing back pain, and it is an ACC issue here, isn't it, Dave, that patients will want to get their back injury under ACC for various reasons, mainly economic. And if they haven't had trauma, ACC wouldn't cover it. And particularly if it's more of a obviously an abscess or an infective process, a discitis type thing, or somebody with a spondyloarthropathy, ACC are not going to qualify that. But it's often young, fit, active men, and they'll say, "Oh yeah, well I'm a builder, so I was lifting bricks, and therefore my back hurt." So you've got to be mindful of those, don't you, with people trying to claim it under injury.
We know that 50% of the time back pain does not have injury, so you should always be wary. And people will come in and say, "I must have injured my back." Well, it's certainly not the case. You may have injured your back, you may not have injured your back. And I guess we're the people who have to sign the forms and things, so we should always be very careful and document carefully what we think and feel. Sometimes I will submit an ACC form and say, "I think this is unlikely to go through ACC." And then sometimes I will not submit an ACC form because I believe there has not been an injury.
And one final news story this month brought a smile to my face when I opened stuff.co.nz and I read the headline, "Urgent Care Centre Takes Pressure Off Emergency Department." And this was a story relating to the newest urgent care clinic in the country, which was opened down in Marlborough, a place where they didn't have anything between their emergency departments and their general practice. And so an effort was made to develop this urgent care clinic. And this story was very positive about the effects it's had on reducing the load on the emergency department. And that's really where urgent care fits, is neatly between those two spheres of emergency and primary care. And you can understand why a patient might, if they only had those two options, why you might think, well, it may not be an emergency, but I can't wait 2 or 3 days to see my GP. So you can understand why they go to ED, but now they've got that other option and it's proving itself. And so it was a really nice story to see in the papers.
Yeah, and you can see the signs outside the emergency department in that article saying, "Stop, is it an emergency? For urgent GP care, go to after hours doctor service." So, and that's, I think, what we're trying to portray. Emergency departments are for emergencies, and hopefully the message gets through.
Yeah. And it's nice to see them using the term urgent care as well, getting away from accident and medical, A&E and that kind of confusion. So a positive story, and well done to the team down there that have been working hard to make that a success. Yes,
Dinesh is obviously one of the doctors or the head of that urgent care clinic, and he's a very good doctor and supports the urgent care college whenever he can as well.
Yep, and for those of you who haven't, if you go back through the archive of the podcast, you'll find there's a profile interview with Dinesh where he talks about this clinic and also the other things that he does. He's got a fascinating backstory in medicine, and it's definitely worth listening to. So I'd encourage people to go back and have a listen to his profile. And yeah, it's a good urgent care news story to end this month with. And yeah, so with that, Dave, thank you again for joining us. We'll be back in February. And then, as I mentioned in one of the bites a couple of weeks ago, the podcast will be doing something at the Goodfellow at the end of March. So our March episode will be something that will be manufactured around the Goodfellow at the end of March. So we'll have one more main episode before then. And we'll keep going with the bites in between. So do please email us with any questions or comments or suggestions. And I keep saying, if anybody wants to partake and appear on this, if you've got any cases or anything you'd like to contribute, then please do. And otherwise, we'll see you, Dave, again in a month. Thanks again for joining us.
Until next time.
And thanks, everybody, for listening.